I am so excited to be here. I love to talk about anything school health. I was asked to keep it somewhat informal here. So what I wanted to begin with is, as medical director, this was something I was thrust into. I had no idea what it meant. This was years ago, and I was put in the position, and it was a life changer for me. Went off the connection for children that I take care of between the intersection of health and education. They are linked. You cannot separate the two. And if we only focus on one, we miss the other. It really changed my life, and it's something I have been doing now for a very long time. And it's been an uphill battle, but I have to share I also am starting to see that there are evidence, not only locally, but statewide and nationally, that things are starting to change, that other people, the light bulb is starting to go off on. But let me begin this way, and let me take off my watch so I have 10 minutes. How many people here are either nurse practitioners, physician assistants, or physicians? Yes! Do you know that I usually go to these things, and I know you, yes. I usually go to these things, and there are no clinicians here, and there's a very good reason for that. As I unfold my thoughts here, I'll go into that a little bit more. So that's another example that things are starting to change. I was almost always, the only person in the room who was the medical clinician. I'm a primary care provider. I spend about 35 hours a week seeing patients. I am an adolescent specialist, which means my age group is a little bit older than City Connect's group, but I am the beneficiaries of those who've come through City Connect's as they get to be teenagers. I spend about 15 hours in the school system doing the medical director position on site, but that doesn't count the number of hours put in integrating and doing things when I am off site. 85% of my patients are Boston Public School kids, so I walk the walk. I am both a partner, like the rest of you, and I am also in the school system. So I get to see both sides of it. And even with that knowledge, it is very difficult for me to connect all the dots. I've got all the right numbers, the backdoor numbers, I've got all the knowledge, but it is still very difficult. Most of my children are doing well. They are inspiring, they manage their asthma, and I help manage their asthma with the help of the school nurse, so we have those connections. We have the policies in place. Same thing with diabetes, sickle cell, some of the more complicated children with multiple issues. We're going schools. When they say, I am at the Mather, do you know what that means? Yes. So that is a step in the right direction. I can tell you that many of my colleagues can't name 5 schools. Not because they're bad clinicians. They're not. They're great. It's just that's not part of what's in their daily existence. But I also have a substantial set who are not managing well. They are not doing well. They have chronic illness, they're not connected, they do not have school connectedness, which to me is a major factor that I always ask about. They may be pregnant, they may be angry, and even though I am here to talk about the physical health, I cannot divorce the psychological behavioral health from what I do in the physical health. That's what all integrated together in my care. So even though I have these issues and I have this knowledge, how do I make it connect? How do I make that partnership from the outside connect with the inside? Okay, so now I'm going to put on the hat inside. That was me as a partner, me as an internal. We have health services, and the nurses, the school nurses, are the foundation, the bedrock of health services. And I don't care if you're talking about Boston, you're talking all of Massachusetts, or you're talking across the country, School nurses are the foundation for the physical school health, and many times beyond that. In Boston, we have 100+ school nurses, and they are spread across. The number of schools keeps changing. One of you can perhaps give a more accurate number, but if you figure about 130 schools, 100 nurses spread across them. Most schools do have one nurse. Some schools have more than one nurse, but a substantial number of schools have to share a nurse. No nurse has more than 2 schools. We've redeployed them for next year. It's going to be a little bit different because the school system has reorganized. It is now having strands based on some of the special needs issues, so there are different strands in different schools, and the nurses are an important part of helping work with those children in the strands. The school nurses, in my estimation, are a hidden, in this country, a hidden source of health care. When we were talking about health care reform, you didn't hear anything come up about school nurses. And yet, in a day, a school nurse will see far more patients than I am able to see in the office. And I have to see patients. I am scheduled every 15 minutes to see patients. And that's a billing thing, that's a financial thing, that is what primary care is about. Every 15, your primary care? So every 15 minutes you're scheduled. Sometimes you get 20 minutes if it's a physical new patient, but, or 10 minutes, you know, and you have to bill to the maximum, and it's billable hours that you're held accountable for, as opposed to, even though there are quality assurance measures, it's really the billable hours that's the engine driving things. The school nurse has to see everybody who walks in the door. Some nurses don't have a big load, but most nurses see triple what I can see in a day. And they don't get to bill for it. It is a service that's provided either by, in the case of Boston, it is by the educational dollars, because it's paid by the school system, or in some communities, it's paid by the health department. But it's not paid for the billing that you usually see with in health. So that, as a background, some of the things that for health services I wanted to make sure people understood are that we have policies that are in place, and that goes from asthma-friendly schools to working for emergency management, how to manage the child with an individual emergency. Those can all be found on the website that is under the superintendent's circulars. And there is a little bit of overlap with what Jill Carter does, but the ones that I am focusing on today, really the ones that are related to the physical health of the child. The latest one we're working on is how to do concussions. A child gets a concussion. How is it managed? And this is a great one because it crosses all the silos. And I do want to have a moment to expound on my favorite topic, is how we are a siloed society. But it crosses all of the different areas that you can think of. The child gets a concussion. That's physical. Who makes the decision that they had a concussion? How does that concussion get followed up? How does the trail of the primary care provider find out about it? Who gives permission for the child to come back? What if the child has some lasting educational, academic issues because they have had a concussion? How do you link that in? How do you do education around how to prevent concussion? All of those cross multiple areas, both internally and externally to the school. And when I think about one of the things that's been the hardest for me as try to push through this aha moment about the intersection of health and education is because we are siloed. Mary mentioned that. It's my favorite word that I hope will eventually go away. But if you think about it, the health world is its own silo. I don't get to talk very much with my mental health colleagues when I have a patient. Very hard to talk to them because we are all very busy. Then you have the public health world that also has its own policies. You have the educational world with its own policies. We are all there for the well-being of children, but we don't necessarily have the time to communicate in the way that works. And children walk between the silos, and we need to walk between the silos with them. And that's just the bigger community. We have categorical issues. Funding comes through for obesity. Funding comes through for teen pregnancy or STDs, the high rates of chlamydia in the city. There are different things that draw our attention. We follow funding streams, but we also follow the needs. But the needs are multiple, and as long as we keep following categorically, That's another silo that kind of keeps us from being able to do what we need to do. And then internally. Internally, in any kind of an organization, there are the internal silos that keep us from necessarily crossing over. No villains, just people who are very busy, have their meetings, have their physical plants in one place, another place. Even the school nurses, 100 nurses with one supervisor, all by themselves, out in a school, not having someone else. They are the only person out there. In a sense, they're kind of siloed too. So we have to figure out how to walk between all of those silos internally and externally. A few last thoughts that I wanted to put that have made connections difficult. The way we communicate to break down those silos. Mary mentioned the confidentiality, HIPAA, FERPA. FERPA is internal to the school system. HIPAA is outside. I'm sure most of you are familiar with that. I'm hoping we're getting beyond those boundaries and figuring out how to navigate those gray areas, but they shouldn't be insurmountable. We can figure out HIPAA, FERPA communications. The rhythm of the school day versus the rhythm of the clinic day. I start at 8:40, I get done at 9 o'clock at night. In that time, I don't have a lot of time to call the school, who, at least with high schools, get out at 1:50. So how am I going to do that? And that's a real mechanical thing that needs to be understanding how we can mesh the rhythms of our day. With me, 15 minutes to see a patient, how can I work that into that? Who do I talk to? Well, I know to talk to the school nurse, and I have to get that information out to the rest of my colleagues about that. What delivery mechanisms? I use the school nurse quite frequently, but we also have school-based health centers. There are other models that we can think of that are delivery of health services within a school system. And it really depends upon what you have for your district, your resources. All politics is local. All health delivery should be considered local too, because it's not the same in Boston as it is in Austin. Case managed, track information, that's my biggest need. And a lot of these things that I'm ticking off, I have to say City Connects has figured out a lot of how to make these happen, and which is why I enjoy working with them for it. Case managing, tracking information, somebody to talk to be able to follow that child. Understanding school etiquette is something that the outside world needs to understand. You as community partners here, I think, get it, but I think my medical world kind of doesn't sometimes get the etiquette of school and working with schools because they're used to their own etiquette, and that's part of the siloing. The more you move them out of their silos, get the etiquette, which is what we're doing now in some of the schools. I work out of Boston Medical. Boston Medical is now working in some schools to understand that etiquette and to bring some of the skills that they have in the hospital to the schools. And the last thought I would have, and Mary mentioned this, is data is powerful. Data is so powerful. The school nurses were fortunate to get from Children's Hospital electronic medical record startup money, and they have taken off and flown with it. Our electronic medical record in the system allows us now to really do analysis. How many kids have diabetes? How many? We didn't know. I mean, we did know. Each nurse knew, but it's by hand. Now we can do things centrally, electronically. We can look at zip codes. Our Wonder Data analysis, Megan Reeves just did analysis that shows where asthma is across the city. And it's very interesting. It augments what the health department's doing, gets a different view of it. Is it because of the zip code? Is it because of the school? What do we need to figure out to help these kids with asthma? So I could go on, but I won't because I have 10 minutes. And I am glad to answer any questions, any gaps that I have left out. I am glad to talk to anybody are we having a discussion? During a discussion and then afterwards. So thank you.